I'm professor of medical genetics, and notwithstanding that I have a medical background, a degree in medicine, and trained as a doctor, I'm not a clinician. And so this is an indication that nobody is perfect. However, the story of my laboratory was focused since 20 years about the molecule CD38 that now is used as a target in monoclonal antibody-directed therapy of human myeloma. And this is a success. I mean, success since now only, is a monotherapy now, this treatment, and quite successful, and was some way a breakthrough in the therapy. And what I did yesterday, being one of the few basic scientists in the audience, to convince the audience that it is necessary to split the activities of basic science and clinical application. It is necessary to know exactly what an antibody does when hit the target. And the target is not, let's say, an inert target. These molecules, like CD38, are ectoenzymes, a name that indicates that the molecule is not a simple marker, but is a molecule which exerts a function in vivo. And this function is probably involved in the effects observed in therapy. I mean, this ectoenzyme is able to produce, to lead to the production of adenosine, a substance which is an immunotolerant. And this is part of the story in therapy. And probably the myeloma is a smart guy that is able to reshape the environment around him in his favor. So everything, as you heard about the bone disease, is addressed to his survival at the expenses of the surrounding cells and the environment. And not only this happens in the, let's say, where the myeloma grows, which is the so-called bone marrow niche. It happens also outside. And so we've shown that myeloma is able to communicate with outside tissues and also with the blood, just simply sending mini cells, the so-called microvesicles or exosome vesicles, and these mini cells are able to deliver signals outside to leave messages inside the cells which are addressed to the defense. And so the defense are blunted, are impaired. And this is what happens in myeloma, where the immune defense is some way decreased. And this is part of the bad prognosis that these patients have. And this is a mini story that ends 20 years of application. The immune system can be stimulated by giving either substance that, like cytokines or interleukins or other things like that, that give positive signals. Another possibility is to impair the population which exert negative effects, like T regulatory cells, myeloma-derived suppressor cells. So on one side, you must give a positive signals, and on the other side, to blunt those leading to a suppression. And so this is a dynamic balance happening in all the tissues and biological fluids of these patients. And the result seems to indicate that antibodies specific for CD38 are able, some way, to induce both of these effects beside the simple hitting the tumor cells. I mean, CD38 is a surface molecule, very which has a very long life in the history of life, phylogeny, has become a target for myeloma, which is an obvious observation. But the same molecules is also expressed by the cells, so-called effectors, which give a positive effect that kill, and the other that tend to do the opposite effect, like blunting this immune. So is a way to reshape the original dynamics between positive and negative effects. This is the side, let's say, action exerted by this antibody in vivo. This was confirmed in vivo by the first trials. The antibody was approved with a special pathway, since was doing pretty well in clinics, and was approved first in the United States and then in Europe, but not yet arrived in, not yet approved in Italy. Yes, it's a single agent therapy, at least in the situation where it was tested. But as I said, I'm not a clinician, so leave the clinician the answer to this.